All right. Hey guys, Abe Ovadia here on the Legally Exhausted podcast. I have with me Dr. Jonathan Walker. We're here today at the Florida Justice Association's workhorse seminar with John Romano. It's an amazing seminar, learning a lot here, meeting a lot of cool people. One of them being Dr. Jonathan Walker here from Ethos TBI. Welcome to the podcast.
Thanks for having me.
Thanks. We're set up here at the Marriott World Center. And saw you downstairs, said, hey, let's do a podcast. And you're like, let's do it. You love talking about brain injuries.
Absolutely. I did Joe Rogan last week, so I figured this would be the next step up. And
yeah, absolutely.
Good way to go.
Yeah. Joe, hit me up. Right. Hit me up anytime. So we've actually, how did I meet you? I met you years ago. I was doing PIP suits for your clinic in Ocala. Back in the day when I drove a Prius with my info on the side of it. I drove up to Ocala, met with you. I actually went through your files with Neil Armstrong, who still works with me. He's
really?
He's the head of our IT now. And we went up there a long time, like over 10 years ago.
Oh, yeah.
And it's been a while. I met Mean Gene. Shout out to Mean Gene. And then you got another Gene up there.
That's Billy Gene. Billy Gene and Mean Gene.
Billy Gene and Mean Gene. He's got two people at his office named Gene. I don't know if that's an Ocala thing or what, but
got no more Genes though. Two's the limit.
Two's the limit, I bet. Yeah. So really excited to have you on this podcast because I known you for so many years. Helping you with the PIP suits, and I know there's a couple other PIP suit lawyers in your life. It's okay. I'm glad that I was one of them. But you are at Ethos TBI. This is a company that you founded specifically for evaluating, diagnosing, treating people who've suffered a TBI, a traumatic brain injury. Can you tell me a little bit about it and tell some of the viewers about it?
It was kind of an interesting journey. Back in probably 2011, I learned about a type of brain MRI that you're very familiar with called DTI, diffusion tensor imaging. And essentially this is a more advanced way of being able to visualize and see the brain. And was very interested in that technology, learned a lot about it, started speaking about it, doing postgraduate education, learned how to really well document traumatic brain injury and all the findings and symptoms and the different outcomes, tools to use, things like the Rivermead, the ACE form, those types of things. But then I had this patient in 2013 that was a probably 75-year-old lady. She had whiplash and she had a concussion. Pretty common combination. What was uncommon was about a month into her care, she said, my neck's fine. Her whiplash had healed, but I'm still having all these concussion symptoms, headaches, dizziness, nausea, blurry vision, memory issues, those sort of things. And it hit me like a ton of bricks. I'm not doing anything to help this person. I'm documenting their injuries and we're putting everything on paper, which is important from a medical standpoint and important from a legal standpoint, but I'm not making this human feel any better.
Right.
And that
You're
was
not treating them.
Correct. So, and that's the traditional in neurology. One of our neurologists calls it diagnose adios. Yeah. You have a brain injury.
Yeah.
Good luck.
Yeah.
Maybe it'll get better. Maybe it won't.
Right.
And so that didn't sit well with me. And so I stood out and did all kinds of postgraduate training and a lot of different seminars and courses and things like that in brain rehab and concussion rehab.
Yeah.
And realized there's a lot that you can actually do for these patients that have a concussion, aka a TBI. And so from probably 2013 to 2018, that was a heavy emphasis of my practice and what we were doing. And then long story short, that led to an introduction to a neurologist in Jacksonville who was interested in incorporating concussion rehab and this stuff into his practice.
Okay.
Dr. Syed Assad. He and I hit it off, kind of nerded out together on brain injury and realized there's a lot of synergy there. And then that's what led to developing our whole platform with neurology available via telemedicine, a lot of diagnostic testing that helps to not only confirm the diagnosis of brain injury, but helps to guide our therapy and guide our treatment for this patient. And so, but it all started from realizing that just being able to diagnose a problem but not really help it, it's kind of a crummy thing. Especially if it's your mother, your spouse, your kid, someone you care about. And so that's kind of led us to where we're at.
Yeah, I remember back in the day, first meeting you, you were big on MRIs. And what I liked about you was you actually knew about specialty MRIs that a lot of doctors still, hey, there's a DTI scan. What the hell's that? What body part is that? No. It's an extra scan they do on the brain. Oh, why? A lot of doctors don't know. This is newer technology that's not new to you, but it's 15 years old in mainstream technology wise, maybe like 15 years, old. Now it's becoming commonplace and more adopted. But a lot of doctors that went to school 30 years ago don't know about it. They don't hear about it. And so that's one thing I want to point out is like you're just a really, like you said, nerd when it comes to.
I try and teach my kids that's not an insult. It's a compliment.
Not an insult. Yeah,
it's a compliment.
I'm a proud nerd as well. I geek out about other things, but mostly Legos for any Lego people.
That is just genuinely nerdy.
I'm building the Avengers Tower right now. I'm so happy, man. I woke up my 10-year-old son and was like, dude, you got to wake up. You got to see this Saturday morning. I woke him up. I worked on it Friday night. You got to wake up and see it. He's like, leave me alone. I want to watch YouTube. But to get back to that. So one, you're an incredibly smart guy. Two, you're a pioneer in the state of Florida. I don't know if anybody's ever told that to your face, but you're a pioneer when it comes to brain injuries in the state of Florida. Everybody's sort of picked up brain injuries after they saw you do it. In my opinion, I haven't found anybody that does it on the scale that you guys do it in terms of the number of locations. And then also the treatment side, actually treating patients, because originally, like I'll give you two for instances. I had a client who was on a golf cart, nice guy in the Villages. He's on a golf cart, old Betty's driving, she boom, hits him. He goes flying, lands on his head outside of the golf cart, big bruise right here, goes to the hospital, you're fine. Goes to an orthopedic, his shoulder's messed up, his knees messed up, everything hurts. Nobody diagnosed this man with a brain injury. I'm talking to the guy. He's one of these guys. I don't need a lawyer, insurance, they're going to take care of me, whatever. They offered him 15 grand. He was a CPA, really smart guy. And his wife said to me, Abe, after the accident, he's never been the same. Change of personality. And I go, change of personality. Now, I knew from talking to a neuropsych down in the Boca area that this guy, any change of personality is a really common phrase from friends and family. Oh, he changed after the accident, stuff like that. And interestingly enough, the guy liked to drink. He was in the Villages. He liked to drink and hang out and, enjoy himself.
There's a lot of that down there.
Yeah. And after that, he never drank again. He had no inclination to drink, which his wife was like, this is a plus, but I need
some sobriety into it.
Yeah. But I need to point it out. And I said, we got to get him to the neuropsych. So I'm talking to the neuropsych. I'm looking at the photo of the bruise. I go, how in the hell has this guy treated this long? And nobody told him about a brain injury, not in the records, not verbally. And so I sent him to the neuropsych. He went from a $15K offer to a $100K policy tender right away. And this was before they had Ethos around, and it was $6,600 for him to do a neuropsych consult, one-on-one. He had to do it there. This was before Zoom and all that. Another person, this is again before Ethos is around, nice young girl, 18 years old, head-on collision in Polk County. All the surgeons, all the doctors, everybody saw her. Nobody said, hey, you have post-concussion syndrome, TBI, whatever you want to call it. I want to find out from you afterwards if there's a distinction. But nobody said anything. She's talking to me. She's telling me her grades are failing. She had to drop out of school. She was a straight A student, all these bad things. Beautiful 18-year-old girl. Everybody's focused on her neck and her low back. Nobody's focused on the brain injury. Again, I set her up with the neuropsych. The offer went from 60 to 180. And she had some issues that didn't make it a perfect case. There was some scumbag psychologist who said something else caused this and that to change in her life, which was just baloney. But anyways, they increased the offer. She was fine with it. But this is all before that. You come around, now you're diagnosing it and you guys are treating it. And you guys don't just like, okay, here you go. You guys have, tell me a little bit about the process for a patient who might have who has certain symptoms and comes to you guys, can you explain the process to me a little bit?
Sure. We call this kind of the patient journey.
Okay.
And so the beginning is getting that initial screening done, and that can be done by a doctor's office, can even be done by a law firm in terms of just a checklist or a questionnaire.
Okay.
Now, obviously, that's not a medical diagnosis.
Can you talk about that river mead test? Because I talk about it with doctors all the time, and they go, I never heard of this thing. But this is a common checklist for brain injuries, which I've incorporated into my practice now. Can you explain that too while we jump in there? Just
Sure. Yeah. River mead is what's called an outcomes assessment tool, which is basically just a way of putting a bunch of questions together about brain injury that ultimately patients checking different answers, and it gives us a score. And it's a way to document their symptoms and then sort of track their progression as they're going through the treatment process.
Okay.
So some type of a questionnaire or a checklist or a screening like that, that's the easiest way for maybe a medical practice or a chiropractic office
That's number 3 now. You hit it one more time, you get a reward, right?
We gotta tape my hand down.
It's all good.
I did 23 in me. I have no Italian in me whatsoever, but I have the gestures.
There you go.
I'll just white knuckle this sofa here.
There you go. It's all good.
Like medical or chiropractic practice that may not specialize in brain injury, or even a law firm, athletic trainers use these type of checklists. Coaches in schools use these type of checklists. That's kind of the easiest way to identify the symptoms that would point towards a TBI.
Okay.
Because, for example, just having headaches alone doesn't constitute a TBI. But if there's headaches and there's dizziness and there's memory problems and there's sleep problems, now we have a presumptive diagnosis of brain injury.
Now, is that a diagnosis, or is it more like leaning towards a possibility? Because I could have, sleeplessness.
Sure.
My shoulder hurts me after a motor vehicle accident. I got headaches because, I got, really bad whiplash. My head rocked forward. You mentioned some kind of scoring. Is that how it works? Like if you have a plus 50 or...
No, it's a little more nuanced than that. That's why I say a presumptive diagnosis, because
presumptive.
The actual diagnosis is not made until the provider actually sees the patient. So just a checklist or a screening doesn't give a diagnosis of brain injury. It just sort of points someone in that direction.
Like, hey, let's check this out.
Correct. This is something we should look into more.
Okay.
Exactly.
Okay, gotcha.
So the initial visit with us is typically with one of our nurse practitioners, and we call that a triage visit. They're going to go through the patient's history, document all of the symptoms that they're having related to this TBI, get a really good understanding of the injury, whether it was sports injury, a car crash, a trip and fall, someone got hit in the head like an assault. There's a lot of ways that you can sustain a TBI.
Wow.
And so ultimately, that initial visit then has a physical exam component as well. So they're going to look at different types of coordination things people might do, looking at their eye movements.
You don't want to use
balance.
that finger to touch your nose.
Yeah, this is the finger that has to stay here. And so all those factors combined, that's what makes that clinical diagnosis ultimately.
Okay.
And so that's kind of step one, is documenting that patient. Then, depending upon the age of the brain injury, if it's been more than a couple of weeks since the trauma, it's really good to start with some concussion rehab, because with this type of therapy, the sooner that it started after injury, the better.
So I got to interrupt you there. Is there a period of time someone possibly, hey, I've got sleeplessness, I've got headaches, when should they be referred or sent to Ethos for this initial triage consultation?
Sure.
Is hey, wait 6 weeks, see if it goes away, or is it just, hey, let's just do it, let's get in there and see what it is?
Really, the sooner the better, because I used to, from a just pure medical standpoint, there's really no problem typically with waiting 6 weeks or waiting a month, so long as they've been cleared that there's no brain bleed, there's no growing lesion, things like that. But from a practical standpoint, what happens is that when you wait 6 weeks, that turns into 2 months, that turns into 3 months, that turns into 4 months.
Okay.
Not only is that not good from a medical standpoint, but then from a medical legal standpoint, there's not symptom documentation.
Yeah.
And so there's a lot of times gaps in the medical legal record of documenting these TBI symptoms. So the sooner the better is what we recommend.
Yeah. These insurance companies sometimes, I had a client who treated right after the accident, 10 out of 10 shoulder pain for months. She's treating with her doctor, didn't get an MRI though. And then later on they go, oh, but her shoulder's fine. She hurt her shoulder from something else. They just don't want to pay. And so what you're talking about is if eventually they ended up paying because she got an MRI and showed a major tear in her shoulder that just never went away. But what you're talking about is, hey, get in right away so that we can get started on you and document, hey, there's this possible issue here. Now we did further testing. We found out that's an issue. Let's start treating medically so that you're better off medically. Is that what you're talking about?
Correct. There's really two sides of the coin. There's the medical side, which is this: if this were my kid, the sooner the better in terms of getting this looked at and potentially starting some therapy. And then there's what a lot of attorneys share with us, which is the medical legal side of having these symptoms as a part of the medical record early on.
Gotcha.
Because unfortunately, most orthopedic doctors, most chiropractors, most pain management doctors, even a majority of ER physicians, there's studies that bear this out, don't diagnose concussions very well because it's not what they're looking for. Right. I don't diagnose hemorrhoids and heart murmurs very well in my facility because it's not what we're treating. And so it's, fortunately, hemorrhoids and heart murmurs aren't medical legally relevant particularly often. But the sooner the better. And then, like I said, the next step after they do that triage visit is just like you can do therapy for your knee, for your shoulder, for your neck, for your back, there's therapy that can be done for the brain. And so that's, as I said, kind of after I had that experience with a patient, that's where a lot of my postgraduate focus has been on learning about neuro rehab and this concussion therapies and things that we can do. There is some testing that we do that serves two purposes. The testing serves the purpose of confirming our diagnosis, because remember, it's a clinical diagnosis, not an imaging diagnosis, not a questionnaire diagnosis, it's a clinical diagnosis made by a provider. The testing confirms that diagnosis, but more importantly, that testing guides the therapy and guides the treatment. So for example, there's a type of testing we do that looks at the eye movements. And we know that the eye movements are one of the most dramatically affected areas with the brain being injured or impaired. It's why a police officer, if they think that your brain's impaired from drugs or alcohol, looks at eye movements. It's a simple, easy way to do. This is a test that uses infrared cameras to measure those eye movements and then graphs them and compares them to normative data. One of the tests that we do that measures eye tracking gives us specific eye rehab exercises to do using an artificial intelligence algorithm so that we can help guide that patient's therapy better. And so that's really the testing serves kind of that dual purpose of confirming our diagnosis, but then guiding the therapy and the treatment we're doing for that patient, or that we're referring for someone else to do for that patient.
What's that eye test called?
That particular test is called oculomotor tracking. And so oculomotor tracking shows what your eyes are following, and it's pretty easy to see what normal looks like and then what an injured or impaired brain looks like.
And is it like a cumulative amount of tests that kind of confirm the brain injury? There's no one test. Is that it?
That's correct. That's a good way to think of it. It's not like a strep throat swab where you swab it and it's either positive or negative. It doesn't really work that way with brain injury. There are some blood tests now that, but they have to be done within the first 24 hours of injury. So they're not super practical. But Abbott Labs actually approved one just a few years ago. It's not really widely used at this point, but
nobody knows about it, right?
Correct.
They didn't learn about it in school.
Correct. But no, really, it's each of these different tests shows brain function or dysfunction. And so we can look at different domains or different areas of function or dysfunction. And when you start stacking all these test results together, it just further confirms that initial diagnosis. So the example that I use is it's like trying to guess someone's ethnic background from their last name. So if I said, all right, your last name's Ovadia. Take a guess. That sounds like a Cuban name. Maybe you're Cuban, right? That's just a guess.
Do you know my ethnicity though?
We've talked about it before. So that's why this is a particularly good example. Because number one, that's just a guess. That could be wrong. You could have changed your name at some point because you thought that Ovadia sounded cool. Your family could have changed their name at Ellis Island when they immigrated. There's a lot of reasons that people's names, you're just kind of wild guessing. However, if your last name's Ovadia and they go, ooh, that sounds like a Cuban name, and your grandmother lives in Havana and you're fluent in Spanish, and your favorite food is, ropa viejas.
There you go.
Some Cuban food. And every year you travel to your second vacation home that you have in Cuba, and you have a bumper sticker on your car that says Cuban and proud, and you're a member of the Cuban American Legal Society, it could still technically be true that all those things are correct and you're not Cuban, but it'd be highly, highly unlikely, statistically improbable for you not to be Cuban if all those things are true.
And it's imposter.
Right, an imposter. And it's the same thing with brain injury. Because like you said, let's say that the balance testing, someone has a condition like peripheral neuropathy where they can't feel their feet, so their balance is bad. Well, it's not just brain injury that causes bad balance. Or the eye tracking problems. If someone has neurodegenerative disease like Parkinson's, dementia, that affects your eye tracking. If someone has, a lot of anxiety and depression, that can change some of your brain waves. But again, that's why we don't look at the tests in isolation. We look at them all together as a whole. And all of a sudden, just like in that Cuban example, it starts to paint this picture of, man, there's really nothing else that can explain what this is other than this brain injury that occurred after a trauma that we know causes brain injuries. Because, for example, car crashes, even if you don't hit your head, just the neck whipping around and the brain sloshing in the skull is a known cause of brain injury. Versus if you're walking through Target and a bag of pillows falls off the shelf, that's not a plausible cause for a brain injury. Tripping and falling and hitting your head, that's a very plausible known cause of a brain injury. Football, contact injuries, getting hit in the head, we've got to trace it back to some plausible biomechanical cause. And then we start looking at how all these tests kind of come together. So you're right, there's not any one, and that's a big mistake to base just off one test, because even some of the MRIs like DTI, there are other things that can cause a DTI study to be positive other than a brain injury. But it's the clinician's job to put all the pieces together.
Do you know Andy Walker, Dr. Andy Walker?
I know of him. I don't know him personally, but I certainly know him by reputation.
I think he just retired. He did, Quote me on that. But he was one of the premier DTI guys doing the NFL studies, doing all these things. If anybody ever said, hey, who's the number one expert on DTI scans, who's been doing it the longest, it would have been him.
He was an early adopter.
And so, he had his own MRI center in Port St. Lucie area. He had people from around the country coming to his center in Port St. Lucie, of all places, to get this DTI scan. NFL players, everybody. In the bottom of his report, I'm misquoting him here. In the bottom of his report, it said something like, I miss 40% of all brain injuries. DTI is not the end all be all. It's kind of, the way you brought up like a blood test or COVID test or something like that. But it's like I always equate it to, it's a good test if it finds something, but if it didn't find anything, doesn't mean that you don't have a brain injury.
Correct.
And I always equate it. It's a horrible equation, but I don't know how worse to make it. Like, you're drinking all night, you go out with your buddies, you get lucky, it's a stranger, and then the next thing you know, he's like, where's it going?
Where's this headed?
You're like, I don't know, I need to go get an AIDS test. And you show up and they go, well,
heavy.
It's, right. Well, that it brings a severity to the point. And you go, well, that's like, we're 60% sure you don't have it. What about the other 40? There's no one test to tell you, hey, you're good, don't do it again, right?
Sure.
And so even with the DTI, it misses brain injuries. But if they get it, are you in agreement? If a DTI finds a brain injury, it's very likely a brain injury. But there could be other reasons for it.
So the best way that I can say it, actually, I listen to a radiologist that you probably know, Sean Mahan.
Yeah.
And Dr. Mahan.
Smart guy.
Dr. Mahan put it, I think, the best that I've ever heard it phrased. He said, DTI is, and again, I'm going to misquote him, but you'll get the gist of it. DTI is very, very good at detecting brain trauma. Or let me back up. That's not what he said. He said brain injury. DTI is very good at detecting brain injury. He said it's the job of the clinician to determine if it's a traumatic brain injury and if it's from a specific event. So, for example, there could be injury to your brain because you've had years and years of high blood pressure. That can cause that can cause DTI changes. So it is injury, but it wasn't necessarily a traumatic brain injury. It's the job of the clinician to say, well, no, this is a traumatic brain injury and it's caused by this specific trauma.
So what other types of diagnostic objective testing do you have? Because I'm sure, someone would say, oh, well, the doctor just says this person has a TBI. What are some diagnostic other tests besides, we talked about the ocular stuff, we talked about the DTI stuff. What other tests are out there, and And can you tell us, I'm fascinated with what you're telling me, like, hey, high blood pressure could cause this. Can you tell us some other things like that?
Sure. So we don't have any cookie cutter battery where everyone gets the exact same test. So we have a large menu to choose from, and it's based on their history, their physical exam findings, different mechanisms of injury, things like that all may play into which test that we pick. So we have the oculomotor tracking we mentioned that shows what the eyes are following. There's another test called video nystagmography that looks like a virtual reality headset, but it has cameras in it, and those cameras are actually recording the eye movements and graphing them. So that test is looking at your eyes. The oculomotor tracking is what your eyes are following. It's like two different sides of the coin with eye movements.
Okay.
We have a special type of EEG. You've probably heard of electroencephalogram, EEGs. They're not traditionally very useful for diagnosing concussions. They really pick up seizures and things like that. Most people with a concussion don't have seizures, fortunately. However, we use a type of EEG that has what are called ERPs, or event-related potentials. This shows us how the brain responds to a unique stimuli. So like, for example, hearing what we call oddball tone, which means you're listening, person's got an EEG helmet on, they've got a headset, just like we've got on right here, and they're hearing a series of noises, and it goes boop, 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 and then it goes beep. And when they hear the different tone, they push a button. We can measure the reaction time, and we have normative data for how long it should take, because with the brain injuries, you might guess. A person of that
age, a person of that. Does it incorporate their level of education, or you don't need that in?
Reaction time really isn't education-based, but age does factor in, because perfectly normal, healthy 80-year-old, perfectly normal, healthy 18-year-old's going to have faster reaction time.
Okay, gotcha.
So we factor that in. But more importantly, it measures the electrical activity of a certain type of brainwave called the P300, P as in Peter 300, that's activated with those, what we call oddball tasks. And this is actually a very important brainwave from a biological standpoint, because if you think of, 500 years ago, or certainly thousands of years ago, our ancestors out walking around in a forest, there's all kinds of background noise that you're hearing. And if you freaked out at every time you heard a leaf snap, or you heard a twig, or you heard the wind blow through the trees, you wouldn't get very far. So your body has to understand that there's background noise and kind of just this constant stuff going on, especially if you're out in nature. However, an oddball task or an oddball tone, that means basically something's either coming to eat you and you need to be aware of. There's a bear, you hear all of a sudden this big crashing through the trees, or something that you could eat, if you're hunting. And so the purpose of this is that our brain's wired and created in such a way that when it hears these out of pattern noises, it stimulates a specific part of the brain.
Gotcha.
We can measure that, and we can compare it to normative data, because again, an 18-year-old's brain is going to respond this way. An 80-year-old's brain is going to respond this way. And you can't fake it. That's what's great about it, is that it's a very objective biomarker. And it's not predicated, or it's not based upon your age, or your education, or your intelligence level, or just human biology. So that's a really cool test that we utilize.
Okay.
And there's a lot of other things that EEG measures as well, ratios of different types of brain waves and things, and other stuff that gives us good information about that patient. There's computerized balance testing, because we know a lot of people with concussions, their balance is off. There's smell testing or olfactory testing, because we know that the most commonly injured cranial nerve from a brain injury is cranial nerve number 1, which is your olfactory nerve responsible for your sense of smell. So about 20% of people with a TBI, with a traumatic brain injury, have some decrease or loss of their sense of smell.
Interesting.
So we measure that with a test called the University of Pennsylvania Smell Identification Test. Basically, it's the world's fanciest scratch and sniff test. Uses microencapsulation technology, which that's essentially what it's doing. And the patient's given this test booklet, and they're smelling these different scents, and they have to tell you what odor they're smelling.
Is it just the expo markers that are like strawberry and lemon and licorice?
It's a much more expensive version of that kind of concept.
I bet.
But it's that same kind of idea of where, do you smell gasoline or do you smell strawberries? The patient's picking which one they smell.
I wonder how I'll do on that, because I got chronic sinus issues. I just got the full body MRI at the place I was telling you. And it said major sinus issues. Like, I think I said, oh, well,
I was curious when I saw the sample report that you had put out there, I was like, I wonder if that's Abe's.
Yeah. I crossed out my name. Yeah.
I was curious. You got a little osteoarthritis in the knee.
I've always had like a thing here, but it's funny. With the MRI center, the first thing I did when I bought it is I went and got all my knees. I got both knees scanned, my shoulders, my spine, everything. And I could have sworn that, after I'd go running, I'd be like, oh, my knees are killing me, man. Once I got the MRI, it came back, no tears. And I go, oh, I'm healthy as a horse. I don't know. And then ever since then, dude, I could run with no pain. And now I just got this MRI. I'm turning 40 this year. It says like a little arthritis in the right knee. And I'm like, oh my gosh. I'm like, I'm hitting it there. But I have been working out. I've been doing a really good CrossFit gym that I love. And it's phenomenal. I have 5:30 morning most days of the week. I think I just started from that.
And hopefully it'll help clear your sinuses out.
Hopefully. I think I got to go see an ENT now that the guy said
So that's a good example, though, of just doing that smell test alone by itself wouldn't be a very good test for brain injury patients because there's a lot of other things that can cause that.
Okay.
But that's where the clinician has to piece that together and say, well, Mr. Patient, do you have any other, did you get punched in the nose yesterday? Do you have a cold? Did you have COVID and lose your sense of smell permanently when you had COVID? Those types of things.
Okay.
So that's why we have to look at a whole array of tests, not just one. There's other tests that we do that looks at what's called your autonomic or unconscious nervous system.
Okay.
So you have your conscious, like when you want to move your arm, you're consciously telling your hand to move. And then you have your autonomic or unconscious part of your nervous system. And that's split into two halves, which is sympathetic, which is your fight or flight, and then parasympathetic, which is rest and digest. That's your more calming part of the nervous system.
Gotcha.
And so we know that in people with a brain injury, about a third of the time, that gets completely out of whack. We call that dysautonomia. And they tend to be hypersympathetic, which means overly agitated, overly anxious, emotionally unstable.
That's why they're so difficult to deal with, a TBI patient. They miss their appointments. They're angry all the time. I had a guy who came into a chiropractor's office and he literally said on his way out, he had a great time there. Everything was cool. On his way out, he goes, go F yourselves. Just walked out.
For no reason.
And they go, what the heck? And then he calls the next day. He's like, hey, when can I schedule my next appointment? They go, you just told us to go F ourselves. And he goes, no, I didn't. Did I? And is that, the guy had he was on a bicycle, had a helmet cracked wide open. And he was never the same after that, the guy, you know?
Yeah, that can be the most severe form of this dysautonomia is called pseudobulbar affect. Pseudobulbar affect, most likely this is what that client had. Another term for it is emotional incontinence. So like incontinence where you can't control your bladder, this would be incontinence where you can't control your emotions. And they tend to be either they'll start crying at the drop of a hat and then they're fine. Or they'll get angry for no good reason. And then 10, 15 minutes later, they're fine. Or sometimes this is the rare one, but sometimes it's inappropriate laughter. Like if you've seen the movie The Joker with Joaquin Phoenix, not a good one to watch with your kids. It's not like, oh, let's go watch a Marvel movie, kids. Pretty dark. But that's a good example of pseudobulbar affect. Actually, if you remember that movie, they talk about how the Joker, Arthur is the character's name, became the Joker from sustaining a traumatic brain injury. And so he had what's called pseudobulbar affect, which is most likely what that client had.
That's the golf cart client too. He was explaining to his orthopedic doctor how he'll start laughing hysterically for nothing being funny. And then start crying.
That's definitely
And the doctor wrote it down, didn't diagnose him with a brain injury, didn't mention it, didn't know what it was. He just wrote it down in the report. Pretty wild, right? Like, can you imagine that? But the only good thing that come out of it is stop drinking, you know? Geez.
So that's one of the tests that we do. And then there's a therapy, because remember this testing helps to guide the therapy process. That's called autonomic biofeedback therapy. So it's a type of biofeedback therapy that helps to sort of smooth that process out. There's also neurocognitive testing that we do. Now, this is not the same like the 2-day long battery that a neuropsychologist would do. They're doing that usually for forensic purposes. We're doing this to help guide the cognitive rehab that we're doing, like brain games on steroids, basically. So we do that type of testing. I think that covers. Oh, there's another cool one. This is the last one I'll tell you. That's called quantitative pupillometry. This is a neat test.
Sounds like a Harry Potter spell.
Right. It's some kind of a wizard thing.
Yeah.
This actually sounds kind of wizard-like because it's pretty amazing technology. So everybody knows that if you shine a light in someone's eye, pupil's going to constrict and then it will dilate back to normal. You go to the hospital, you go to a doctor's office, that's usually one of the tests they'll do.
Yeah.
That tells us if there's like gross neurologic function, like someone's in a coma and they're looking to see if their eye still constricts or not.
Okay.
However, quantitative pupillometry uses high-speed cameras and it measures, and we're talking in a matter of milliseconds. This is so quick you can't even process it.
Oh, wow.
How fast the pupil is constricting. Is there a delay in constriction? How much is the pupil constricting? And then is there a delay for it to return and dilate back to normal?
So all these different data points.
All these different data points.
You can't fake it. There's
even if you knew how.
Yeah.
Like I know exactly what it's testing, and there's no way that I can go, all right, pupils, I want you to go extra slow, boys. Ready?
Right. Yeah.
But that's a really useful biomarker that it's easy to assess. So that can be used sometimes throughout the patient's treatment.
Okay.
To see how they're responding and how their brain is objectively changing or not changing with the different therapies and treatments we're doing.
Yeah. And with some of the pioneering stuff that you're doing with the brain injuries here in the state of Florida is the treatment. And a lot of people, I'm talking about 10 years ago, there was no, you got a diagnosis, you got a diagnosis. That's it. There's no treatment.
Right.
There's no place to treat. You guys offer treatment. Can you tell us a little bit? I've been hearing a lot about hyperbarics. I've been hearing a lot about these Candy Crush type of games to help regain some elasticity in your brain is what I was told. I don't know. You're the expert here. But things like that. What do you guys offer in terms of therapy?
Sure. So under kind of the TBI rehab umbrella, because let's first start a little more broadly. There's kind of 5 different domains of treatment.
Okay.
So there's counseling and referring them out for counseling with a licensed mental health counselor, social worker.
Okay.
So if someone has PTSD, they have anxiety, they have depression,
right,
that can be really, really helpful.
And those could be from a brain injury.
Absolutely.
Yeah, okay.
Absolutely. Okay. So that's the first domain. Second domain would be medications. And so, like, for example, that pseudobulbar affect that we were talking about, there is a medication that can be helpful for that.
Okay.
Most of the medications, though, are more symptom management. So meds that can help with headaches, can help with anxiety, depression.
Gotcha.
Our neurologists don't medicate a ton. Our nurse practitioners don't medicate a ton, but in some cases they will. So there's medications. Third domain would be there are some interventional procedures that exist for headaches and for PTSD. There's a procedure called a stellate ganglion block that actually goes in and hits the stellate ganglion that sits right here on your carotid with an anesthetic block. And it knocks out a lot of the adrenaline production that takes place with PTSD. Oh. There's a hyperadrenaline response in many cases. So it's like rebooting the computer.
Okay.
There's some other interventional procedures.
Is that commonplace? I've never heard of that.
It's most commonly done in the VA setting because there's so many vets with PTSD.
Right.
But there are a handful of, it's usually pain management doctors, and it's often people that are double boarded in pain management and neurology.
Okay.
Because it's a procedure that most of your standard bread and butter pain management doctors aren't going to do because there's not a lot of conditions that require it. And it's a very delicate procedure. It's going right here. If you go too far, you kill the person.
Gotcha.
So it's not as commonly done as like an epidural or a facet block or something.
Okay.
The next category would be regenerative medicine. So there are some regenerative therapies with things like stem cell exosomes, intranasal PRP, where there's actually platelet-rich plasma like you might get for the knee or the shoulder is introduced through a catheter intranasally. And we actually started doing that a little over a year ago.
Oh.
I came across a sports medicine physician in Colorado that pioneered and actually patented this procedure. He's been doing this for years, mostly with skiers and snowboarders and athletes and people with concussions not related to a car crash or personal injury case. And so we learned this procedure from him and have been incorporating this into our clinics.
Wow. Okay.
So I'm going from like, these are the less common things to then the most common is what you asked about, which is call it TBI rehab or concussion rehab.
Okay.
Underneath that umbrella, hyperbaric oxygen could fit under that umbrella.
Okay.
We utilize normobaric oxygen. There's a new therapy we just started adding last year, and I just last week scaled this to all of our clinics. It's called molecular hydrogen inhalation therapy.
Okay.
And so it's using, instead of inhaling oxygen, it's actually a type of hydrogen that's inhaled. And the effect that that has on decreasing inflammation in the body, particularly in the brain, the effect that it has on stimulating mitochondria, which are like the powerhouses and the powerhouse, energy centers, if you will, really, really effective for a lot of conditions, but particularly for neurologic conditions.
Okay.
A ton of research out of mostly Japan and South Korea on molecular hydrogen.
Isn't it crazy how here in America, we're behind the times when it comes to new ideas and medical research and new treatment plans? It's like, oh, that's available in Europe, but not here. Why is it available in Europe and not here?
Well, follow the money.
Yeah.
We are one of only 2 countries in the industrialized world, the other being New Zealand, that allow pharmaceutical companies to direct advertise to the consumer.
Yeah.
So you've probably traveled abroad to Europe, and you'd go to Germany, you go to England, you go to France.
Only been one time, and I was on a cruise, but I'm excited to go again this summer.
Well, you'll notice when you go there, and when you flip on TV just to see what's on, you won't see any pharmaceutical companies.
Yeah.
You won't see any billboards. You won't see it in the magazines. You won't see stuff out there. We're the one country besides New Zealand in the industrialized world that allows that.
Yeah.
And so, of course, and unfortunately for brain injury, I guess fortunately, unfortunately, there is no magic pill. There is no FDA-approved drug for brain injury. And so a lot of this stuff, sadly, we kind of lag behind.
Yeah.
You mentioned Candy Crush. We call that cognitive rehab. So it's like brain games on steroids.
Okay.
There's a treatment that we use called infrared photobiomodulation that uses infrared light therapy. It's an array of infrared diodes, wraps around the head, stimulates blood flow to the outer part of the brain.
Okay.
Blood flow is a very good thing when you're trying to heal. There's a technology we use called the alpha stem. It clips onto the ears, and it has a mild electrical current. Sounds like shock therapy, but it's not. It's almost an imperceptible sort of feeling, but it stimulates alpha brain waves. Alpha waves are very calming, focused, very beneficial healing type of brain waves.
Okay.
There's a technology we use called vagus nerve stimulation. The vagus nerve, I mentioned olfactory was one of your cranial nerves. Vagus nerve is your longest cranial nerve. And we stimulate this with a small microcurrent that clips on. You can't see it with the headphones, but the little nub called the tragus right here on the inner part of your ear.
Okay.
And it's particularly helpful with headaches as well as other symptoms neurologically we see with traumatic brain injury.
Okay.
Balance therapy. Some of these patients are going to benefit from balance therapy.
Okay.
What
is balance therapy, like core training?
So more like things with wobble boards and balance boards. And,
okay.
Helping to reconnect the circuitry between the brain and the rest of the body.
Okay, gotcha.
Vestibular rehab would kind of fall in that category as well. I mentioned eye movements. There's what's called oculomotor rehab, which is retraining your eye movements that can get messed up from a concussion. We talked about that biofeedback therapy called autonomic biofeedback therapy. We are just rolling out in some of our clinics some virtual reality-based brain rehab.
Wow.
Which is really, really cool. There's a lot of really neat applications. I think in the next 10 years.
One of my brothers started a virtual reality video game.
Really? I didn't know that.
First-person shooter, yeah.
Very cool.
Called Vail, V-A-I-L. I'm very proud of him and
shout out
both
to
of them, actually. Yeah. So if you need any help, you let me know. I'll hook you up.
V-A-I-L.
Yeah,
like Vail, Colorado?
Yeah. It's a first-person
you
shooter.
Shooting skiers or what?
No, it's like a Counter-Strike.
Gotcha.
I don't know if you know that game. Yeah, Counter-Strike.
Gotcha. So so I'm always looking for new technologies and new therapies that we can be adding. There's a new device that we're adding that uses what's called audio-visual neurostimulation.
Okay.
And so it's like a headset that the patient closes their eyes, and there's lights that are very gently flashing in certain colors and frequencies, and then they're listening to what are called binaural beats, and it's specific frequencies that have an effect on the brain. So really neat stuff. The idea that you can't do anything for a concussion, that's just outdated science.
Yeah.
And so it's really important for people to know that.
These treatments weren't well known 10 years ago.
Some of them weren't even existing 10 years ago.
Yeah.
Correct.
Wow,
but certainly weren't well known.
Yeah. Yeah. I wish the clients that I had, I met with the whole reason I know about brain injuries is because obviously the field that I'm in, but I met a neuropsych, Dr. Salmonson down in Boca, who's a really smart guy, knows everything there is to know. He educated me a lot on just looking for a brain injury, and it's not hard, but doctors aren't trained.
Right.
So I'm glad that, Ethos is around to help evaluate, diagnose, and then even treat people. This was all like super informative. My mind is blown. We got to get out of here. How can people get a hold of Ethos TBI, get a hold of you if they want to be treated, learn more about it? What's the best way?
Sure.
You guys have a website, contact info?
Yeah, the best thing to do is check out ethostbi.com. And so ethos, ETHOS, TBI is in traumatic brain injury. So ethostbi.com. And that'll give you a lot of information about what we do, some biographies of our neurologists, our locations. It talks about the testing and the therapies.
Awesome.
That's really the best place. And there's contact us. If you want to become a patient, you can put in your information. My team will reach out and get you set up.
Awesome. Well, really excited to have you on the podcast.
Thank you.
You're a really smart guy. I've known you a long time, and I'm really happy that you're here to educate me, but also the viewers who can learn about TBIs and all that. So thank you for being here, and we'll get back down to the seminar, I guess. Huh?
All right.
Cool.
Thanks for having
bud.
me.
Thank you.
Sorry for